Hello and welcome to another Blue Tree Banter session where we talk to industry experts and get their take on important topics in the world of healthcare. I'm your host, John Price Hamlet, and today's episode is going to focus on aligning operations with technology and some of the strategies that we use to improve the relationship between those two things. I'm super excited to be joined by my group of panelists today. Before we get started, let's do a quick round of introductions, and then we'll dive right into some of those more interesting topics. Ian, if you wouldn't mind kicking us off.
Sure, John Price. Thanks for having me. I'm Ian Doughton, and I am the Executive Medical Director for Tegria Clinical Solutions, and I'm an emergency medicine physician in Seattle, Washington.
Hi, I'm Sonia Frisbee. I am the Clinical and Nursing Informatics Coordinator at Deaconess Health Systems in Evansville, Indiana.
Hi, my name is Nora Vasilova, and I'm a consultant on the Clinical Optimization and Delivery team, and I'm based in New York City.
So, like I mentioned before, we're here today to talk about strategies for aligning operations with technology to bring out the best in both. Ian, I know your team has been in the business of improving organizations operationally through improvements in their workflows for quite some time now. And I know that one of your main tools that you lean on there is simulations. So can you tell us a little bit more about how simulations are used to highlight some of those opportunities for change, both at the bedside and within the EMR?
Basically, when we're doing simulations, we're bringing realistic teams together to practice in the real environment. As an example of this, if we're going to do sepsis in the emergency department, we'll bring together physicians, nurses, and techs, and we'll do the work in a real ED room. Additionally to that core team, we'll bring in other folks like radiology or lab technicians or even the IS folks to participate in the simulation. And basically in a real granular sense, we bring a mannequin or sometimes a standardized patient, we make them get really, really sick, and then we have the clinicians do their work. So that's clinical work, like in the case of sepsis, they're going to give fluids, they're going to give antibiotics, as well as interacting with the EMR. So they're going to do the documentation that they need to do, they're going to put in the orders to trigger the clinical work to happen. And then we have facilitator teams that are there observing the interactions. And so when we facilitate, we have a physician and a nurse. They are debriefing everyone on the team. So basically going from person to person, what worked, what was hard, what would you do differently? And we ask everyone on the team because we often find that the way that one member of the team does things has downstream effects on other folks. And I'll share here, I've been an ED doc for about 20 years now. And until I started doing the simulation work, I had very little understanding of what happened after I put an order in the computer. So I didn't know how to get a med from pharmacy. I didn't know the actual work of putting the antibiotic into the patient. And sometimes I can get them in my own way by not knowing that. And so when we all talk about the work that we do, we understand the why of when we might need to put an order in a particular sequence. And then also their IS colleagues can see the clinical context of their order sets and tools. And understanding the clinical why can help them develop better order sets and alerts. And then having everyone involved in that discussion at the bedside in the setting of patient care helps them build consensus and buy-in and make sure that the tools are usable from day one. And then from the simulation side, our team collate all the findings, and this is anything from missing equipment to refined workflows, and we report back to institutional leaders and help them develop a roadmap for clinical improvement and safety with those user-validated workflows and supplies and EMR tools.
And so, Sonia, I know that you guys also incorporate simulations into the work that you do with your clinical informatics group. Would you mind touching on that a little bit?
So one of the things that we really focus on with training is starting right as soon as the nurse and the tech get into the organization. And so we have created what we call Simulation Day, which is really where we just kind of bring it all together, try to bring those pieces of what they learn about the EMR together with what they've learned about practicing and patient care, and just bring both of those things together that makes more sense to them. So we have Simulation Day. A lot of what we cover in there are exercises that we used to do in our EMR class. It used to be 2 days long, and we have pared that down to 1 day. We've taken out a lot of the monotonous exercises that they used to do and added some meaningful simulation. So one example of a simulation that we do is the admission workflow that the nurse does when the patient comes into the hospital. And so we have a lot of questions that we ask the patient, and it can get really easy to just go down the list of questions and for the nurse to not really understand why they're asking all of the questions that they are asking, and get really tasky related to that. So we actually have a clinical informatics specialist, two clinical informatics specialists in the room. One is being the instructor and one is playing the role of the patient. And we have all of the new nurses that are in class kind of go around and go through those different questions. The one clinical informatics specialist will be the patient and kind of they have a lot of fun with it. They play the role of the patient. The other person is in there to train. So they'll stop on each section and really explain the why behind why we're asking the questions. The other thing that we do is in new nurse orientation and tech orientation class, they have a lot of material that they cover in that class, and we will go in there and we have a portion of each day, even though we don't train the whole class. It is a nurse that trains the class, but we go in and we do the EMR section where if they're learning about how to care for a patient with a chest tube, we are taking them through how to add that chest tube into the EMR, how to document the assessment in the flow sheets to make sure that they're assessing all the pertinent pieces of that chest tube and how the patient is, responding to that, how to document the output. So it really pulls it all together and they're not as separated as they used to be. So we're trying to pull all those pieces together so that it makes sense whenever they get to the unit.
Now, it sounds like simulations benefit a lot of different people in different ways. So you've got your stuff on the clinician side where they're benefiting, but also from an IT perspective, you're getting a lot more insight into the needs of your clinicians and how they're using those tools in real life scenarios. And to be, kind of blunt with that, it sounds like that's a no-brainer that you would want to be able to do that. But in my experience, the design of the EMR doesn't necessarily always align with the needs of the actual workers at the bedside, which kind of leads me to my next line of questioning here, which is, what other strategies have you used in the past to successfully incorporate operational needs into the design of the EMR?
I think that's definitely a really important point to call out. We should always be thinking of taking care of the patient at the forefront of implementing new technology and how to do that better. From the IT perspective, we can often get caught up in pushing the latest and greatest functionality just because it's available, but we constantly have to stop to think, what problem are we trying to fix? Will that actually improve patient outcomes or increase provider satisfaction? And are we able to get the operational engagement needed for change management to really see that improvement? Because, we can implement even the best functionality without that operational engagement and trust, and that would be a waste of everybody's time. So, for example, when we're looking at designing and implementing machine learning or predictive analytics, it's really exciting new technology that can be leveraged to help make more accurate clinical decisions or identify patients that need specific care. But it's important to first address what those operational needs are, because spend the time and resources implementing a predictive model and make risk scores available to clinicians. If they don't understand how that score is being generated, why it's included in their workflow where it is, why that score should be trusted to be accurate, or what value they might gain from it, then you can spend all that time implementing it without actually providing value. And I think what really helps in these instances is taking a multidisciplinary approach early on and including clinicians from different disciplines from the very beginning, often so they not only understand the technology, but they have a say in how it's built, they get excited about the use cases, and they can then champion it to their peers. And there are always opportunities for getting operations and end users more information, changing their workflow for the better, and increasing ROI in places they haven't thought of yet. But the point of integrating clinical experts into your EMR implementation goes both ways, in that they give us feedback and expertise we can't succeed without, and we can give them the tools and practices that they might not have known that they needed.
Yeah, I'd jump in and I completely agree with you, Nora. I mean, I think the real key is to show the clinicians the why and engaging them in really integrating it into the work. And so they see how it makes their work easier because they come to work every day to take care of patients. And if you can show this is something that's really going to make your work better, easier, make your patients more consistently have better outcomes and make your care safer, those are really, really important things to push on. And the earlier I think you involve the end users, they're going to be more validated as they go, and they're going to be really integrated into clinical workflows. So one isn't bending to meet the needs of the other one. They're sort of designed in parallel and really truly integrated. And the other thing I would say is, Nora, you touched on, multidisciplinary, provider involvement. I think it's really important that in addition to like the department heads and administrators who tend to get roped into this work a lot, I think we really need to make sure that the folks who spend more time taking care of patients than going to meetings in this work, really to get the end users to really validate that we're making the right choices to operationalize these things really well and get the full value from the tools.
So I think those are all very valid points and lead right into what I was going to say about our team. Our team of clinical informatics specialists, we do the majority of the training for most applications at our organization. And our biggest win has really been having those clinicians make up that team. Really, we started out with just registered nurses, and we do train providers as well. We recently added a respiratory therapist, which has really given us some insight that we haven't always had. So we did start with RNs, and within that group of RNs, we definitely have different specialties. So we've got surgical nurses, we've got emergency department nurses. All those different perspectives really help with those conversations at the beginning of projects and making changes. So the other thing about our clinicians that make up our training team is that we still work at the bedside. So there is a portion of hours that are dedicated to their time so that we can still understand workflows, understand really what those clinicians need, understand struggles that we're having with the system and maybe some things that need to be enhanced or changed. And then it helps us have credibility with the staff. Our team motto is bridging the gap. And so I know that's used a lot, but we really chose that at the beginning because we saw ourselves as that in between between IT, who's doing the build, and those clinicians that need a voice. Our staff that make up our training team, we also are out on each unit. So we basically have assignments, and each informatics specialist has different units that they're responsible for, sharing monthly changes to the system with the staff, going to those monthly meetings where the clinicians can give us feedback, and then we take that. Sometimes we put a ticket in for it. Sometimes we work right with the analyst to try and fix it if it's like a break fix type of thing. We also sit on all of the hospital core care teams. We can give bedside clinician input, plus we can give the input of what's happening in the system. And then also at the nursing council level. So we have shared governance and we have practice council where we can go not only share with the nursing staff, but really give input and get their buy-in and see what it is that they need rather than it just coming from upper leadership.
So I'll move on to our next topic here, which is the importance of not only measuring the clinical KPIs associated with the work that you're doing, but also figuring out ways to measure the successfulness of the tool, essentially, that you put into place. What can you guys tell us about measuring the adoption rate, for some of the tools that we put in place, and what strategies have you seen be used in that area?
Sure. So I would say measuring adoption is incredibly important. If you spend the time and resources to build really great functionality, and then you don't spend an equally significant amount of time and resources to not only communicate the change, but communicate its value, means we'll fall short of what we're hoping to achieve. So I think the metrics can be very complex, but you can take an approach, whether it's quantitative or qualitative, looking at everything from actual compliance numbers to using surveys to understand why adoption rates may be where they are. And as an example, I've worked with some organizations that struggle with low adoption rates when it comes to surgeons placing electronic orders. But once that low adoption rate has been measured, it can be used as a springboard for change when we go back to the why. So Has the value of the functionality been clearly communicated to surgeons? Are they aware of the ROI? That we can demonstrate a direct correlation between the adoption of electronic orders and the reduction of case cancellations and delays, which can really have an impact on their bottom line. And it's not just a matter of mandating the use of the EMR. We have to be able to market it and sell its value to our end users.
Yeah, and the why is really important, and it goes both ways so that we have the operations and technology goals aligned. And then our IT colleagues understand the clinical context of their work, and they can help build tools that support the goals. And for clinicians, it's really important to connect the uptake to things that matter, like outcomes, as Nora mentioned, or things that, just bug them on a day-to-day basis about coming into work. So, to go back to my example about sepsis, show them that patients who use the sepsis order set did better. It's easy for clinicians to view sepsis bundle compliance with a fairly jaded view that that's only something about, it's CMS and it's about money and these other things that they don't care as much as they care about their patients getting better. So make that connection with the data and show them. And I'll share that when in a prior life I was a department chair, and I'd hear from certain docs that they couldn't do something I was asking all the physicians to do because they all felt that their patients were different for various reasons. They were sicker, they were more complicated, they were more difficult, lots and lots of different reasons. And I found that sharing blinded individual provider level data, showing that their colleagues who were practicing the exact same ED with the exact same type of patients were able to have better outcomes by using the tools. And that really spoke to them. And you can kind of exploit the competitive nature that all these docs at least have. So it worked to gently just, kind of nudge them in the right direction.
So we do look at measuring impact, and adoption rates after. But one of the things that we have started doing more of is really trying to see what the impact is going to be to the end user before we ever even implement something. In the past, what we found with those poor adoption rates is that we didn't have enough clinicians involved prior, or we didn't have the correct people at the table to help work through those workflows, or maybe we didn't have the correct data collected. And so we ended up basing the change on information that wasn't really what we should have been looking at. And so one of the things that we do with our best practice advisories that alert us in the system is we have a clinical decision support team, and every request for this pop-up alert in the system has to go through that team. And that team has started doing more research on the front end and having things like run in the background. And we've talked a little bit about those predictive analytics. We do that with those predictive analytics as well, and trying to figure out really what is going to be the impact to the end user. So if we put in an alert for the nurse, for example, one of the alerts that we may have is the patient has a problem of diabetes. We need to have the diabetes clinician come see them. How many times is that alert going to pop up? And are they going to end up getting alert fatigue? Is it really meaningful? Is it going to make a difference? Or is it something they're already doing that maybe we could see a little bit of a bump up in utilization, but maybe we won't get our full bang for our buck there, and maybe we need to look at something different. It's real easy to say when we're struggling with something that we need the EMR to give us an alert to remind us. But what we found is that we had a lot of alerts. We were having a lot of people ignore alerts. They just got fatigue, and it was just like alert after alert. And so this team is trying to prevent, frustrated providers related to BPAs firing too often or inappropriately. Even looking at options for timing. So how often does the alert fire? Does it make sense for it to fire this many hours after, or should we extend that? Is it okay? Is it best practice to make sure that we have something completed within a certain time frame, so we do need that alert? But it is really important, and where we've seen a lot of help with this is trying to measure those alerts in the background and see what that impact will be before we ever even put it into production.
Okay, so I know we're getting pretty close to time here, and I'd just like to take a moment and kind of summarize some of the things that I heard today, some of my takeaways. One, simulations can be super powerful tools for process improvement and have tons of ancillary benefits like increased end user engagement and buy-in. And if you're introducing a new workflow, or if you're looking to increase efficiencies in the system, it sounds like it's a good idea, to figure out a way to incorporate simulations into your project plan. To how we introduce tools into our process and present them to our users and how we integrate them into the system is just as important as the actual functionality associated with the tool itself. Listening to you guys, it sounds like it's really important to make sure that we engage our users early and often, and make sure that we have those clinical champions that are backing up our initiatives, so that we can have those successful work efforts. Then three, and I'm just kind of pulling this together from a lot of this information here, which is having a really strong informatics team or a group of individuals that kind of serve in that capacity can really close the gap between operational need and technical design. So it sounds like if anybody out there that's listening might be struggling with change management or end user satisfaction, forming an informatics group or a similar group of folks may go a long way into addressing those issues. Those of you out there listening / watching today, if you're interested in learning more about how Bluetree might be able to help you employ any or all of these strategies, let's talk. I'd like to thank you all for joining us today, and I'd especially like to thank my panelists here. You guys were awesome. Appreciate you guys taking the time to talk with us today. And as always, look forward to talking to you again.